and then the neurologist will follow up on that CT scan result right away, and then if there's no change, he will order the verbal order or on the computer TPA order. And then the neurologist will say, there was no change on the CT, as we agreed, I gave the TPA. So the neurologist should always work together with the ED doctor. You shouldn't be wondering, was the TPA given or not? Okay? You should always be aware of what happened to the patient. And so that's it. Now, the second page is in case, ideally, a neurologist is the one that does this, but sometimes in case you are the one that having to get the consent of TPA, I provide you with some routinely used discussion statement here on the TPA discussion for consent from the patient or POA. So the way I say it, I bolded down below that that's what I use, but I use a shorter version of that. So basically what I tell them is, right now you are most likely having a stroke, and for this we give IV TPA. And IV TPA is very effective. About 30% of people who get it completely recover, and they do well. But there's a risk of bleeding, and that's about 2 to 6.4%. But most people do well. But we need to give this medication as soon as possible, because the more we delay, less effective it is, and more likely to bleed. So do you want us to give this medication? I've had about 5%, 4% of people say no, and the rest of people will say yes. So the discussion of TPA can be very brief like this. But that's a sample a lot of people use there. Now I put there 3 to 6.4%, hoping that our facility will achieve that. But if our facility ends up being 5%, then that's what we need to say. Lower number, 5% to 6.4%. But like I said, most facility across the United States, it's about 2 to 3% risk of bleeding. Again, the risk of bleeding is most common cause, incorrect last known well time. Giving the TPA when there is a clear hypodensity indicating near complete stroke. And the most common one is blood pressure after the TPA is started. The idea is the upper parameter is 180 over 105, but some nurses may think that they use that parameter just like the way they do it with other blood pressure parameters. So they're thinking, okay, if we go over the target, we'll do something about it. I will alert the MD if it go over the target. But what happened is it's too late. By then it's already bleeding. So the idea is it has to be kept below the upper limit of 180 over 105 at all times. So the action needs to be taken if it's hovering over 170, over 100 or 98, etc. You need to act on it right away. So that's the best way. So as long as the blood pressure is well controlled, last known well time is accurate, the TPA complication with bleed will be very minimal. It could be under 2%. Okay. I think that's all the information I have for now. Any questions?
And just to let everybody know, we'll have all that modified NIH scale plus kind of our new stroke algorithm process posted and sent out to you and on placards in the ED. So for anybody furiously taking notes, don't worry, you'll have a little card to go by. Yeah, and we'll get those out so you guys can see in that case and not have to remember all of it. But the modified NIH will be saving a ton of time for us, and we'll also have kind of a clear, consistent scale that not only our nurses are using, but we're using. So I'll get all that information out to everybody here soon, and we'll have placards in the ED as well.
All right, thanks very much. Hopefully that video is useful.
Yeah.
I'm going to add just a couple other things. For those that are on the phone, this is Shelby. Good morning. One piece that Dr. Ahn talked about when we talk about disability, because we've had this with a couple patients. Some patients don't understand what disability means. So like Dr. On specified, can you do you feel that you're still able to do your job or can you still, walk around the house, or just define what disabled means, because the patient in their brain, they may not think they are disabled, even though they can't move their, arm.
Right.
So specifying that.
One thing about that is, so the guideline and expert opinion is that what happened is that sometimes the initial stroke symptom may be very minimal. It may be a facial droop or a slight weakness grip on the arm. But then what happened is that as time goes, that clot further migrate upward and cause more symptoms. So later, 1 hour later or 5 hours later, the patient may have more deficit at that point. So because of that, and because of the effect, the beneficial effect of improvement with TPA, even with the minor symptoms, the guideline says that keep the TPA, even if the symptom deficit is minor. Now, when is the time that we don't give the TPA? When the patient came in with a symptom, and that is if the deficit has fully resolved. In the past, they use a vague language of rapid resolution. So people misinterpret it as say, oh, patient is now significantly improved, so let's not give the TPA. No, that's actually a wrong approach, because what happened is that sometimes the clot move and the symptom fluctuate. So the patient may be better now, but then later, a few hours later, it may get worse again. And so because of that, the only time we don't give TPA is the initial deficit is fully resolved without any residual deficit. Then we say, okay, no TPA. But if there is still some residual deficit left and it's minor, still the TPA should be given. Yeah.
Thank you. Renee Smith has been promoted to our new stroke coordinator, with me having oversight over the new FEDs that are being built. I just can't do it all. So we have promoted Renee to do that. So you will be getting information and stuff from her. Part of our annual stroke education that you guys get for one of your credits is, many of you probably remember at the physician area, we had a folder that went through kind of just the algorithms, the updates. So there's a sign sheet, so you can do an attestation. I know Alexa in the past has sent out and will send this out, that you can do a computer response, email response attestation.
That was sent to everyone yesterday.
Perfect. So yeah, we just need to make sure we get those in to get your credit that you're aware of our stroke program. And additionally, part of being a stroke accredited program, if the surveyors ever were to come around and say, do you know where to find your clinical practice guidelines? All of you should say yes, because we have them at about 5 or 6 places in the department and on all the units in the hospital. But on every code cart is our book of codes. So code blues, falls, a lot of different code grays, things in here, but there's a whole folder tab on strokes for intracranial hemorrhage, just general stroke guidelines, thrombolytics. All the clinical practice guidelines are here, and when we get updates, we replace those. So those are your Bible, the manual of why we do what we do here, and what Dr. On follows, because that's evidence-based practice from the American Heart, American Stroke Association. So know where your clinical practice guidelines are.
All the updated algorithms are in there too.
Yes. I think that's it on stroke.
Anybody have any questions after all that? All right.
This is Gina DePraw. Thanks, Dr. On. That was really helpful.
One more thing. If you after you gone through the short process of NIH that I described, if you are still kind of unsure, kind of doubtful that does this patient have expressive aphasia or not, you don't have to try to look for that NIH picture thing with the 5 items. You could just use any of the 4 items that you have, such as you can ask, what is this? The ring. I'm pointing out to the ring here, and you can ask, what is that? You can show the item that you have, which is pen, or the flashlight, okay, or the badge. So anything you have on you can be used to test the expressive aphasia and the naming capability. So the whole idea is to not to lose that 1 minute, try to shorten that time for TPA. Okay?
Good.
All right, thank you.
Thank you,
Yeah.
really appreciate it.
Yeah.